Hello, my name is Tori Boyer, student in Nurse 707 Clinical Inquiry 3. I am pursuing my Doctor of Nursing Practice DNP degree specializing in pediatric primary care at Maryville University in St. Louis. I would first like to thank you for taking the time to view this presentation. This project is entitled Optimizing Red Blood Cell RBC Transfusion Guideline Fidelity in a Pediatric Intensive Care Unit, or PICU. This is a Doctor of Nursing Practice scholarly project. It is performed and presented by myself, Tori Boyer. Community members. The community members involved in this project include my appointed chairperson, Dr. Rita Wunderlich, Nurse 707 faculty, Dr. Maria Snell, my community committee member, and Dr. Alan Doctor, and myself. Background and significance. Background. Red blood cell RBC transfusions are commonly prescribed to patients in pediatric critical care units who are considered to be anemic, despite dangerous clinical implications associated with overtransfusion and the non-existent methods for predicting anemia-related decompensation. It has also been found that transfusion decision-making, or TDM practices, vary between organizations and can even differ among intensivists who practice within the same institution. Nasser et al. 2017 note the critical level of hemoglobin that will improve oxygen transport and oxygen delivery, or DO2, in critically ill children is uncertain. Nevertheless, most providers prescribe RBC transfusions because the concentration of hemoglobin has reached a threshold that seems to be associated with inadequate arterial oxygen delivery. Despite the insufficient evidence supporting the use of hemoglobin level as a sole indicator for the need to transfuse, many providers continue to make their decisions based on this metric alone. This leads to explicit overtransfusion. Furthermore, there are numerous complications associated with RBC transfusion. There have been significant improvements in blood product collection, storage, and management, which have reduced the dangers of pathogen transmission. However, the occurrences of non-infectious serious hazards of transfusion, or NESHOT, persist. Adverse reactions to transfusion include transfusion-related acute lung injury, also known as TRALI, transfusion-associated circulatory overload, TACO, alloimmunization, and transfusion-related immunomodulation, such as TRIM. TRIM can be measured by hospital-acquired conditions, also known as HACs. Moreover, RBC transfusions are clinically proven to be associated with poor outcomes in the pediatric population. Recent literature suggests red blood cell transfusions have a notable relationship with increased mortality rates in the ICU, more so when prescribed to those with underlying comorbidities. Research also shows a significant correlation between RBC transfusions and increased PICU length of stay, mechanical ventilations, and rates of new or progressive multiple organ dysfunction syndrome, also known as NP-MODS. Clinical Practice Guidelines 2018 Taxi Guidelines. The use of appropriate clinical judgment regarding the need to transfuse is essential for healthcare providers to enhance patient outcomes and quality of care. The use of restrictive transfusion threshold guideline from the American Academy of Blood Banks AABB and updated guidance for RBC transfusion decision-making in critically ill children from the Pediatric Critical Care Transfusion and Anemia Expertise Initiative both strongly encourage withholding RBC transfusions when the hemoglobin level is greater than or equal to 7 grams per deciliter. To moderate variation among prescribers, increase adherence to taxi guidelines for restrictive transfusion threshold, reduce NESHOT events, and improve care of a pediatric population, a concentrated PICU care provider educational seminar was employed as a quality improvement initiative and evaluated for this DNP project. Significance. Significance to healthcare can be seen as additional research regarding transfusion triggers and the development of patient blood management programs at the chosen facility might emerge post-investigation. Moreover, once adopted, the Restrictive Transfusion Threshold Guidelines, TAXI, will reduce the overprescription of RBC transfusion at the chosen facility, and patient outcomes in this pediatric critical care setting will be improved. Purpose and aims. For this scholarly project, the author evaluated a quality improvement educational in-service provided to pediatric intensive care unit staff for the purpose of addressing a care provider knowledge gap related to transfusion overuse and knee shot occurrences in the critically ill pediatric population. The purpose, again, was to evaluate and improve PICU providers' compliance with the current CPGs, TAXI, and determine if the QI education on TAXI was effective in reducing overprescription of RBC transfusions and the incidence of knee shot in this pediatric population. This DNP project was therefore a post as compared to pre-implementation of the QI initiative evaluation. The author conducted a retrospective electronic medical record EMR review pre- and post-implementation of the QI to compare providers' compliance with the proposed clinical practice guidelines. The overarching aim being to increase providers' adherence to the CPGs for prescription and thus advance patient outcomes at the chosen facility. Further, the author developed this project to achieve three specific aims. Specific Aim 1, to reduce overprescription of RBC transfusion. Specific Aim 2, to reduce select knee shot occurrences. And Specific Aim 3, to evaluate the relationship between fidelity to the clinical practice guideline and incidence of knee shot at this unit. Review of literature. To better ascertain complications associated with RBC transfusion and gather evidence related to restrictive transfusion guidelines, a detailed appraisal of scientific literature was performed. The Discovery Search tool within the Maryville University online library database was utilized. To initiate the exploration, the phrase red blood cell transfusion and pediatrics was entered. The primary search yielded 93,170 works. The results were screened by the author to identify studies that examine outcomes of RBC transfusion in the pediatric population, from which 6 primary research articles were identified. Furthermore, keywords restrictive transfusion, pediatrics, intensive care, and clinical practice guidelines were manipulated to generate 4 additional primary works. The search tool was also utilized to identify the current recommendations for RBC transfusion in infants and children. These guidelines, again, were developed as a part of the Transfusion and Anemia Expertise Initiative and will be referred to throughout this presentation as TAXI. The total number of publications yielded from this search was 10 primary articles in the current practice guideline, TAXI. Review of literature continued. Themes revealed. Upon completion of database exploration, a comprehensive and systematic appraisal of literature was performed. Despite the differences in study designs, method, and analysis, this investigation led to the discovery of 4 main themes related to the implications of RBC transfusion in the PICU. These concepts consist of Theme 1, there are increased rates of RBC transfusion in the pediatric intensive care unit. The review revealed RBC transfusions are prescribed in about 10 to 40% of pediatric and neonatal patients admitted to the pediatric intensive care unit, most of which occur in the first 24 hours of admission. Of note, transfusion rates are increased in patients who are admitted to the PICU given their age, severity of illness, and diagnosis-specific predispositions to anemia. Moreover, those admitted post-operatively or with a diagnosis of trauma, including GI or circulatory and pathology, malignancy, or heart condition, are at an increased risk for transfusion. Theme 2. Transfusion rationale is variable among prescribers, particularly with regard to the use of a transfusion trigger. There is significant variability in the use of a specific biomarker or transfusion trigger indicating the need to transfuse. This discrepancy exists both within and across institutions. Theme 3. Implications of reflexive RBC transfusion. The literature review supported the hypothesis that there is a substantial knowledge gap related to the complications of liberal transfusion practice and risk associated with transfusion. These risks include knee shot. Several knee shot events are acknowledged in recent literature, including mistransfusion, trolley, taco, volume overload, infection, and immune dysfunction, which eventually lead to impaired organ function and worsen clinical outcomes. Theme 4. This review revealed risk associated with liberal versus restrictive transfusion guidelines in clinical practice. Several of the articles compared the use of liberal to restrictive clinical practice guidelines. The benefits of using restrictive practice were evident and well substantiated. Many PICUs have adopted restrictive transfusion clinical practice guidelines as they are strongly encouraged by national associations such as the AABB and TAXI. Theoretical framework. The conceptual framework that was used for this project is the AHRQ model of knowledge transfer. This model fits within the constructs of the project as the intent is to promote patient safety and improve outcomes through the translation of research into practice. Of note, the AHRQ model of knowledge transfer is a multiphasic framework intended to guide the dissemination and implementation work of patient safety research. The author used this model as a guide to design and evaluate the QI project of teaching providers about RBC transfusion guidelines, offering significant benefit to PICU staff and their patients. Methods and design. This retrospective investigation is an evaluation of a quality improvement QI project, both quantitative and exploratory in design. Participants were not directly engaged for the purpose of this project, and no patient identifiers were abstracted from the electronic medical records, further referred to as EMRs. The primary stakeholders at the chosen facility, including PICU division head, medical director, nursing leadership team, and director of the blood management system, have demonstrated support for this project. To gather data for this investigation, the information was extracted from the EMRs at the selected facility. Prior to the launch of the QI initiative, the prescription of red blood cell transfusion was made based upon healthcare providers' clinical judgment alone without regard to the current CPGs. To address this issue, the following strategies were implemented by the facility. An education on TAXI guidelines was distributed to PICU providers by the PICU leadership and research team members via regularly scheduled PICU providers care conferences between October 7th through November 8th of 2020. The launch date of the TAXI guidelines in the PICU was November 9th, 2020. The author was then requested by the Pediatric Intensive Care Unit leadership to evaluate the QI initiative. The QI education largely focused on the TAXI guideline transfusion decision tree, as seen in the figure to the right. The figure is a summary tool created to facilitate simple adherence to the guideline. The author conducted a retrospective EMR review, pre- and post-implementation of the QI initiative for comparison of providers' compliance with the TAXI CPGs. The overarching intent, again, was to evaluate providers' compliance with TAXI to reduce overprescription of red blood cell transfusion and the incidence of knee shot in a pediatric population, thus improving our patient outcomes. Methods and design continued. Data collection. The data collection tool was developed by the researcher using the 2018 TAXI guideline decision tree and information gleaned from the author's literature review on knee shot events. With regard to timeline, there were several steps required in the data collection process. First, an electronic list of patients who received a transfusion of RBCs at the chosen PICU during the pre- and post-launch of the QI initiative timeframes was provided by the Blood Bank Management System Director. The author was permitted access to EMRs provided on the electronic list using their existing employee ID. The firewall-protected and encrypted laptop used to access the information was maintained in a locked location with the author per facility policy and IRB regulations. The abstracted data constituted the minimum data necessary to complete or accomplish the goals of the project. For the purpose of this investigation, data collected included descriptive cohort data, information relative to CPG Fidelity, including hemoglobin and diagnostic category, and C, the incidence of select knee shot events, including transfusion-related acute lung injury TRALI, transfusion-associated circulatory overload TACO, and transfusion-related immunomodulation, again measured by hospital-acquired conditions or HACs. Sample. The QI project educational intervention took place via virtual PICU conferences at the chosen facility. This unit admits approximately 1,000 patients per year. On average, 28 patients receive a blood transfusion in the PICU per month. Regarding sample size, it was expected that 154 records would be reviewed for this study. The author anticipated there would be approximately 77 records examined pre and 77 records post timeframes for this retrospective chart review. This sample size was selected based on proportions of 0.4 and 0.6, with a standardized significance of 0.05 and power of 0.8. Sample continued. All EMRs of pediatric patients who were birthed to 21 years of age and received a transfusion of red blood cells in the pediatric ICU from July 6 to October 6, 2020 were included in the pre-QI cohort. Those admitted and received a transfusion from November 9, 2020 to February 9, 2021 were included in the post-launch of the QI initiative. All races and genders were eligible for this study. If the EMR had documentation that the patient was not between birth to 21 years of age or did not receive treatment and transfusion during the scheduled timeframes, the EMR was closed and no data was retrieved by the author. Additionally, if the EMR had documentation that the patient had a diagnosis of hemorrhagic shock or massive transfusion protocol was received, meaning greater than 40 mL per kilo of blood products in 24 hours, the EMR was also excluded from the analysis. Data analysis. Two-sample z-test. A two-sample z-test was used as the primary inferential statistic method to make comparisons and draw conclusions about the data. Using the two-sample z-test, the researcher was able to apprehend the differences between proportions of the pre-QI initiative and post-QI initiative datasets for A, fidelity to the CPG, and B, the number of NESHOT occurrences. Phi test. To determine whether there was a dependable relationship between the two variables, fidelity to the guideline and NESHOT events, a correlation analysis, or Phi test, was performed as both variables in the analysis are dichotomous. Results. Demographics. Study participants included those ages 0 to 18 years who were admitted to the PICU at the chosen facility. A majority, approximately 70% with an N of 83, were infants, ages 0 to 12 months. 53% weighed less than 5 kilos, with an N of 63. The population was comprised of approximately 52% N of 62 Caucasian and 48% N of 57 from other ethnic groups. The study included all genders with 57% male and 43% female. Figures on demographic data are depicted to the right. Results of the z-test. A total of 81 EMRs were included in the pre-intervention group and 38 in the post-intervention group. Provider adherence post-education was not significantly greater than pre-education compliance. Additionally, the ratio of NESHOT occurrences after the education was not significantly greater than those pre-education. Results of the Phi test. The Phi test revealed a non-significant weak correlation for the pre-education group and a significant positive correlation between fidelity to the guideline and NESHOT occurrence was identified post-education. All in all, the post as compared to pre-implementation analysis of the QI initiative revealed an insignificant improvement in adherence to the current 2018 prescribed guidelines. The correlation analysis performed to establish if there was a reliable relationship between the two variables, fidelity to the guideline and NESHOT events, also revealed a non-significant result in the pre-education group and a very unexpected significant positive correlation post-education. This implied as adherence to the guideline improved, there was a reliable increase in NESHOT events or undesirable outcomes. Strengths and limitations. Study strengths. The conclusions demonstrate the importance of providing continued educational efforts to improve fidelity to the 2018 CPG's TAXI. The PICU leadership team supported the project throughout the implementation and evaluation process. The study offered PICU clinicians across all disciplines information about the current CPGs and ways to improve outcomes by reducing NESHOTs within this unit. This study was generalizable. The data collected from EMRs was representative of the population of interest, a critically ill pediatric cohort admitted to the chosen facility. Limitations. Design. The virtual educational design of the QI intervention was limiting as PICU providers and RNs were requested but not required to attend the in-service or view the recorded QI presentation. The author attempted to mitigate this limitation by making the recording available to all providers to watch at their convenience. However, attendance and viewing was unmeasurable. Validity. The QI project did not result in a significant improvement in fidelity to the CPG or reduction in knee shot events. Yet, the total number of transfusions prescribed post-education was reduced, which may suggest an underlying improvement in adherence to the guideline over the 3-month time frame, thus signifying a possible threat to the validity of the conclusions, as the outcomes of this investigation may not be adequate representations of the hypotheses for which they were intended. Overall, the effect of these limitations on the outcome of the study are not quantifiable. As such, the results are sustained, indicating further education of the current CPGs to improve fidelity and reduce knee shot events is necessary. Discussion. Again, the results of the study are not enough to validate the educational intervention's effectiveness to improve provider fidelity and patient outcomes at the chosen facility. The results revealed that provider adherence to the current CPGs was not significantly improved post-education when compared to pre-education. Similarly, the ratio of knee shot events post-education was not significantly greater than the pre-education group. However, the number of overall transfusions prescribed post-education was significantly reduced from 81 transfusions to 38 transfusions, which may be suggestive of an underlying improvement in adherence to the guideline. The fee test correlation revealed a non-significant weak correlation for the pre-education group and unexpected significant positive correlation between fidelity to the guideline and knee shot occurrence was identified in the post-education group. This positive post-intervention correlation was unanticipated as it suggests that as fidelity to the guideline increases, knee shot or undesirable events also increase. The data analysis performed for this project support the aims of this investigation. However, a significant result was not identified. Therefore, the outcomes of this study demonstrate the importance of providing continued education interventions for PICU clinicians to improve fidelity to the CPGs. Implications. In future studies, it is vital to address challenges that might hinder a provider's ability to employ and document the use of TAXI RBC transfusion decision tree. Likewise, providing ongoing educational opportunities about the current CPGs and routine feedback about the current transfusion practices at the chosen facility is essential. Additional research regarding transfusion triggers and the development of patient blood management (PBM) programs or care bundles developed to enhance transfusion therapy by reducing the onset and improving the tolerance of anemia might emerge from this study. Nursing practice. The outcomes of this study promote the need for continued education regarding the 2018 guidelines and incidence of knee shot events. Additional efforts are needed to institute healthcare policies to increase adherence and, as a result, improve both quality of care and patient safety. This project validates the need to develop a standardized healthcare policy to improve compliance with the current CPGs at the chosen facility. The investigation serves as a pilot, demonstrating areas for improvement concerning prescriptive consistency and documentation of adherence to the guidelines. Incorporating certification of CPG fidelity will promote a reduction in unnecessary transfusion and knee shot events and enhancement of patient outcomes among this population. Such practices can be applied not only to the RBC TAXI clinical practice guideline, but also to various other practice guidelines with low-level compliance. Conclusion. RBC transfusions are a much-needed part of clinical practice. However, liberal prescription has been associated with hazardous clinical implications or knee shot. Despite recent development and endorsement of a standardized transfusion clinical practice guideline, inconsistencies among prescribers still exist. This QI project offered an educational intervention to enhance provider fidelity to the newly established clinical practice guidelines TAXI. The DNP project was conducted at the chosen facility with an aim to improve adherence to the proposed guidelines, reduce the incidence of knee shot among the pediatric population, and determine if there was a reliable relationship between the two variables. The data analysis performed for this project support the aims of the investigation. However, significant and valuable result was not identified. In future, continued educational in-services on TAXI will be provided to clinicians to further enhance fidelity to the CPGs and improve our patient outcomes. Questions. I would also like to open this forum up to questions. Please comment with any inquiries and/or additional feedback. For additional information about the study, you can contact myself, the corresponding author, at the email and phone number listed below. References. Here are all references used in the creation of this presentation. Thank you again for taking the time to review this presentation. Again, a special acknowledgement to Dr. Rita Wunderlich, Dr. Maria Snell, Dr. Alan Doctor, and the Facility PICU leadership team. Thank you.